So, all right, I'll be presenting three abstracts. The first one is a combined molecular and immunological stratification strategy for immunotherapeutic treatment of high-risk endometrial cancers. This was presented by Dr. Florien Ejink at Breukelen, Netherlands, in a Dutch tumor immunology meeting in 2016 in June. So going back, we all very well know that initially on histological grounds we used to classify endometrial cancer into two groups of diseases, type 1 and type 2. But we know the pitfalls of this classification. We know there is a lot of discrepancy even in the classification system amongst pathologists, and it doesn't translate into therapeutic implications as well as we would like it to be. Then came the Cancer Genome Project. In 2013, they classified endometrial cancer into 4 groups. I'm sure we have been talking about this from the morning. The 4 groups were ultra-mutated, MSI hypermutated, copy number low, which is somewhat endometrioid-like, and copy number high, that is serous-like tumors. So these were the 4 groups with distinct properties, and they had different prognostic implications, with pole group doing extremely well. So as I said, pole-mutated cancers are having ultra-mutated genome. That means they have lots of genetic changes, lots of mutations, and probably lots of new antigens to present. They have a very rich inflammatory stroma. This might be, again, a consequence of the mutations that have occurred. And immunoadaptive resistance may be present in these tumors, and that is why they are able to evade the immune surveillance from the body. The MSI group, again, it has got a hypermutated genome, which are rich inflammatory stroma, and immunoadaptive resistance is again present in these. The copy number low group has a genome with very few mutations, and they have a very poor inflammatory stroma. The other 4th group, that is a serous-like, has again few mutations, poor inflammatory stroma, but they have higher levels of B7H4, which is a immune inhibitory molecule, and it is a pathway which inhibits or mediates immune tolerance in the tumors. Unfortunately, we don't have molecules that target this molecule at present. So the Dutch group had previously done a study where they evaluated the pole group of endometrial cancers, and what they sought out was to see whether they are having an inflammatory or inflammatory background or not. So they took out samples from the PORTEC studies, and amongst those, the samples that had pole mutations, they were studied, and they ultimately concluded that ultra-mutated pole proofreading mutant endometrial cancers are characterized by a robust intratumoral T-cell response, which correlates with and may be caused by an enrichment of antigenic neopeptides. And they further thought that this might be a mechanism for the excellent prognosis of these cancers. With this background in mind, they took upon all the samples from the Trans-PORTEC Alliance, and they thought that they will study all these inflammatory mutations and changes in all the 4 subgroups on molecular basis and try to correlate these changes. So microarrays were constructed from tumor tissue from 116 high-risk endometrial cancer patients from institutions of the Trans-PORTEC Consortium. They assessed pole, MSI, P53, and the copy number low status with Sequenom, mass array system, and the Jin-Carter assay version, which are standard things. They also used Sanger sequencing for pole, Promega microsatellite instability analysis system for MSI. Further, they did IHCs for CD3, CD8, which are T cells, T helper cells, CD103 positive cells, CD27 positive cells, and for the TIA, TBET, which are basically differentiated T cells, then CD20 positive B cells, CD45 RO positive memory T cells, and also PD1 staining. They further did immunofluorescent staining in groups and tried to correlate. We'll see later on. And they, on the lines of TCGA, they also did a RNA sequence analysis. They tried to predict antigenic neopeptides using a defined algorithm, which has been published in previous papers. So coming on to the results of the study, they compared the low mutated and P53 mutated tumors, and with both pole mutant and MSI clubbed together, these demonstrated increased density of CD3 positive T lymphocytes, cytotoxic T lymphocyte marker CD8, and intraepithelial T lymphocyte marker CD103 within these tumor centers. So that means the tumor centers had rich inflammatory infiltrate in POL mutant and MSI tumors. Within the infiltrative margin of the tumor, CD3, CD8, CD103 or CD20 infiltration did not differ significantly between the 4 subgroups. They also saw that there was an increased infiltration of memory T cells and mature T cells in MSI tumors. There presence of more CD45 Rho positive and TIA positive cells in POL mutant as well as MSI tumors compared to the other 2 groups. The infiltrative margins of MSI tumors contain more memory T cells and more TIA positive cytolytic T cells, but there was no difference in differentiated CD27 positive naive T cells and TBET positive differentiated T cells. The other copy number low group had more TIA positive lymphocytes compared to P53 mutants. Also, they assessed PD1 and PD-L1 by IHC, and they saw that there was an increase in infiltration of PD1 positive and PD-L1 positive lymphocytes in POL mutants and MSI tumors. So they took out a median score, and based on a median score of 14 PD positive cells, 1 positive cells in core of all patients, 73% in POL mutants, almost 70% in MSI patients had expression. 31% and 43% in the P53 mutant groups were categorized as high infiltrated with PD1 positive cells. And within the tumor center, 100% of POL mutants, 70% of MSI had high infiltration. Strikingly, only 1 tumor sample, which was a P53 mutant, had PD-L1 staining tumor cell. Within the infiltrative margin, high number of PD1 positive cells within POL mutant group compared to POL mutant and MSI group was seen. Again, they also saw the expression of PD-L1, whether it's being expressed on the tumor cell or on the myeloid cells. So when they did co-expression studies using immunofluorescence, they saw that CD68 positive and or CD163 positive, which are markers for myeloid cells, including macrophages and dendritic cells, these were found in the stromal regions within the center of the tumor. Co-immunofluorescence staining shows frequent co-localization, indicating that PD1 may be expressed by these cytotoxic T cells. PD-L1 expression, it co-localized with these CD68 and CD163 positive PDL cells, and PD-L1 is not mainly expressed by tumor cells. So that is why they said that the expression of PD-L1 was basically on the tumor cells, the tumor infiltrating lymphocytes rather than on the tumor cells. They did a tcGNA sequencing, and they found that this was correlating with what the Cancer Genome Project had shown. In conclusion, they concluded that POL mutants and MSI subtypes, these are the groups that harbor high densities of PD1 and PD-L1 expressing immune cells. The high number of CD8 positive and PD1 positive cells in POL mutant and MSI tumors suggests the presence of high number of tumor-specific T cells, which targets neoantigenesis in these neoantigens within these groups. And patients with low intermediate risk disease carrying POL mutations have an excellent prognosis under standard treatment. Most of them are early stage, and checkpoint inhibition is unlikely to be appropriate for these patients. But the rare patients with POL mutant and advanced disease and the patients with MSI with recurring or metastatic disease are possible candidates for such interventions, which should be studied. The other POL mutant tumors, colorectal, brain, breast, pancreas, and stomach, may also similarly benefit from immunotherapeutic strategies. There was some subgroup of P53 mutant tumors with an enhanced anti-tumor infiltrate, and they need to be studied for further immunotherapy applications. So moving on to the part of application of these things, so there were 2 abstracts presented in ASCO 2016, both from the Keynote 028 study, which is a basket trial containing many advanced solid tumors. This is the subset of endometrial cancer patients. So in a background, there were previous reports of a few reports reporting that patients with POL mutated or MSI, that is MSH6 hypermutated patients with endometrial tumors, they respond beautifully to nivolumab. Again, one more study which showed a patient responding to pembrolizumab in POL mutant endometrial cancer. This is a phase 2 study where they studied multiple cancers. They took 3 groups. One was colorectal MSI, the second was colorectal non-MSI, or rather the MMR group, and the third was non-colorectal with MSI. In this, they saw that patients who had mismatch repair deficiency, be it colorectal or non-colorectal, they tended to benefit with immunotherapies. There were 2 patients only of endometrioid subgroup in this study, and both of them responded well to study treatment. So with this background, they took PD-L1 positive advanced endometrial carcinomas with ECOG PS of 0.1 after failure of systemic therapy and with measurable disease. Study drug was pembrolizumab 10 mg per kg every 2 weekly, and the primary endpoint was overall response rate. Treatment was continued until PD or toxicity occurred. 24 patients, median age 67 years. Most of them had good PS, and there were 62% patients who had priorly treated with 2 lines of therapy. Median follow-up was almost 70 weeks. There were no major toxicities, no grade 4 toxicity or mortality. Grade 3 toxicities were few, and they were back pain limited to only 3 patients. One was back pain and asthenia, which was resolved, diarrhea, which was resolved. Only 1 patient had asthenia, anemia, and hyperglycemia along with hyponatremia, which was not resolved. Otherwise, they had mild toxicities like pruritus, asthenia, fatigue, pyrexia, and decreased appetite. Overall response rate was approximately 13%, and 3 more patients had stable disease. Median response duration was not reached at the time of data cutoff in December 2015, and 6-month PFS was 19% with a 6-month OS of 68.8%. All patients who had PR continued on therapy at the time of data cutoff. So to conclude, pembrolizumab is active in heavily pretreated advanced endometrial cancers. 6-month survival is encouraging, and safety profile is quite consistent with what we have seen in the other trials of lung and the other sites. A second multi-cohort phase 2 study is underway to further evaluate the role of pembrolizumab in these patients. So I did a search and I found almost 24 studies for immunotherapy or pembrolizumab in endometrial cancer. So the future looks to be something which is promising. Pembrolizumab in patients with advanced cervical cancer from the same study, a different cohort. This was the 3rd abstract, and it was again presented in the ASCO annual meeting in 2016. So it's an unmet need in advanced cervical cancers, and the rationale is that if we inhibit the PD-1, PD-L1 axis, again, tumors will start getting subjected to immune responses. Similar design, unresectable or metastatic cervical cancer, failure of or inability to receive standard therapy, ECOG PS 0 or 1 with measurable disease, and PD-L1 positive tumors were subjected to pembrolizumab treatment. Overall response, primary endpoint was overall response rate, and the secondary endpoint was PFS, OS, and duration of response. So median age was 41 years. Most of them had good performance status. Almost 80% at PS0. 96% were squamous cell carcinomas and 4% with adenocarcinoma. Most of them were metastatic. Prior radiotherapy was 96%, and most of them had received platinum. So this was a heavily pretreated group, if you can see. Overall response rate in this trial is again 17%. 4 patients had PR, no CRs. Stable disease again in further 3 patients. And almost 16 patients had progressive disease in a subset of 24 patients. So 38% of patients had some degree of decrease in the target lesions at the time of data cutoff. And most of these responses, they tended to occur around 8 to 16 weeks. And after that, they continued to maintain that response and didn't progress further. Treatment exposure, median duration of time to response was 8 weeks, and median response duration was 26 weeks. PFS median was 2 months, 6-month PFS 21%, 12-month PFS of 8%. Similarly, OS was median of 9 months and 6 months of 67%, 12 months was almost 30%. So to conclude, pembrolizumab had durable anti-tumor activity in patients with PD-L1 positive advanced cervical cancer. It demonstrates promising overall survival of median of 9 months with a 6-month survival rate of 70% almost. Safety profile is consistent with other tumors, and it seems to be manageable. The clinical benefit, again, is being studied in the multi-cohort KEYNOTE 158 trial. Thank you.